Good afternoon, everyone, and welcome to the ELI-EMR Epilepsy Educational Webinar. First, let me introduce myself. I'm Dr. Fatma Kamoun, a pediatric neurologist and epileptologist from Sfax, Tunisia, and I will be your moderator for this webinar. The topic today is about the episodic ataxia, the expanding epilepsy phenotype of CACNA1A. And it is a pleasure to have with us Dr. Hala Mohammed Musa from Mauritania. She is board certificated pediatric neurology from a clinical experience with the US and Africa, specializing in complex neurological disorder in children. She founded and led Mauritania's first pediatric neurology service and maintaining active research partnerships with Baylor Genetics and the UNC Neurosurgery. Passionate about neurogenetic and neurodevelopmental conditions, she will share with us her experience. So thank you for being with us for this webinar. Thank you also for all the audience members, and you can send your question in the Q&A box. So, Dr. Hala, the floor is yours.
All right, thank you so much, and I apologize for the inconvenience of being late, but I think we'll have enough time for the presentation and for the slides. So I'm going to go ahead and share my slides. 1 second. Let me just go back to the Zoom here. Where is the slide sharing function? Oh, there. Okay. Where does it?
In the bottom, we have a screen. In the bottom.
Okay, yes, I can see that. But can you guys see my presentation? I don't know.
No, not yet.
No. Okay. Do I go back? One second. I'm not sure why it's giving me trouble here. Share. Okay. All right. I think I had to activate something about my... Yeah. Okay. Can you see my slides now?
Yes, just full
Okay.
screen.
All right. Can you see them in full?
Perfect.
Okay, wonderful. All righty. So first of all, thanks to my colleague Haifa for giving me the opportunity. I would like to lead off by saying you're probably wondering why a general child neurologist is embarking on such an ambitious topic. And to illustrate why this became an interest, I'm going to start with a case presentation of a patient that I was recently referred to last year, which kind of cultivated into me going deeper into trying to understand CACNA1A. All right, oops. 1 second. Obviously, I have no disclosures. So the presentation. So this was a patient that was initially presented to our pediatric neurology office here at Sinai with staring episodes that were occurring over the past year when he was 3 years old. They had increased in frequency from monthly to daily, which prompted the parents' attention. And he was noted at the time to have a developmental language disorder, some expressive language delays that were very minor. The neurologist that had initially saw him noted some lip smacking episodes in the office. So in the initial hypothesis, this could be focal impaired awareness seizures. There was no family history of seizures or delays. but when the EEG was completed, it showed the classic 3 hertz per second spike wave activity, and ultimately the patient was diagnosed as absence epilepsy, and as you guys know, the first-line therapy is ethosuximide. So he ultimately failed the first-line therapy of ethosuximide. There was a lot of back and forth in terms of medication non-adherence, but once the parents maintained adherence to the medicine and the levels were within pretty high therapeutic range, there was no seizure control. And so he was seen by our epilepsy specialist and 2 other epilepsy specialists, ultimately started on Depakote, yielding some moderate control. And one of the epilepsy specialists, as I reviewed his history, noted that there were some headaches and dizziness. Ultimately, in 2024, 2 years after his initial diagnosis, whole exome sequencing was completed, and it was revealed that he had a pathogenic CACNA1A variant that was maternally inherited. So I'm going to come back to the story and what my involvement was in this series of events for the patient. But first, we're going to kind of go through what we know today about CACNA1A and how we can kind of fit it into that particular clinical presentation of the patient. So my learning objectives today is to try to kind of briefly look at the historical paradigm shift in our understanding of this channelopathy, and describe the diverse seizure phenotypes, look at the mechanisms, the gain of function versus loss of function variants, and some of the emerging targeted pharmacotherapies. So CACNA1A was first mentioned or first noted in 1996 in relationship to episodic ataxia type 2. And so early on, it was associated with a lot of our paroxysmal disorders, such as the episodic ataxia, familial hemiplegic migraine type 1, and spinocerebellar ataxia type 6. So it's a predominantly adult or young adult focused condition. It was with the next generation sequence era when we started to look at neurodevelopmental cohorts and realized that there were several patients that had CACNA1A, and epilepsy also came into the limelight, I think around 2015. In 2026, we do think of this, the epilepsy phenotype of CACNA1A as a core phenotype, especially in pediatric presentations of this condition. Right. So just some basic science overview. I won't get into any, nitty-gritty details, but just kind of give you an understanding or a refresher of what this gene codes for. So the gene itself, the gene locus is on chromosome 19, P13, and it codes for the primary pore-forming subunit of the P/Q type channels. And actually, the gene codes for 2 different proteins, one of which is much more relevant to your spinocerebellar ataxias type 6, which we won't really go into. But the one that is relevant to our discussion codes for the P/Q type channels. And it acts as a synaptic gatekeeper. And it's highly concentrated in presynaptic terminals, especially Purkinje cells. And that's why cerebellar dysfunction is a core feature in a lot of patients that carry this disorder. And so it controls voltage sensitivity, so depolarization opens the pores, allowing calcium to a calcium influx. So although we think of CACNA1A as a rare disorder, it is not so rare. So in one cohort, back in 2022, 1% of children with early onset refractory epilepsy harbored CACNA1A, and in 2 to 3% of cohorts with autism carried CACNA1A. And this is on the right here, a beautiful illustration, kind of overview from the CACNA1A Foundation, where it shows the different phenotypes that are associated with this disorder, including neurodevelopmental differences such as autism, your ataxias, your epilepsies, migraines, the cerebellar atrophy, and the paroxysmal eye disorders or eye disorders in general. So, as I had mentioned, there's a lot of neurodevelopmental features with CACNA1A, especially in the pediatric presentations. And among those features are your developmental epileptic encephalopathies on one spectrum, and then your atypical absence epilepsies on the other end with regards to epilepsy. So there is this continuous of severity. So it is not one distinct disease, but there's a continuous genetic spectrum. And interestingly, there's an age dependence. The symptoms appear to evolve as the neural circuits mature throughout childhood. And there are some cases where even epilepsy improves with age, although not completely, not complete remission, but some improvement. So, some of the barriers or some of the things that make it a very complex condition is that there's a lot of variants of uncertain significance that are associated with this disorder. And the other thing is that there is this just profound variability within the same family. So you can have one family member that is mildly affected and another family member with the exact same mutation that is severely affected. So it makes it difficult to rely purely on family history to guide your counseling. So having other tools to try to better counsel patients on their variant and their phenotypic presentation is important. So with regards to epilepsy, as I had mentioned, 90% of epilepsy that is related to CACNA1A is pediatric in onset. The median age of onset about 8 months. And earlier onset correlates with neurodevelopmental delays requiring aggressive early control. So epilepsy is a core pediatric feature. So there's a lot of different epilepsy phenotypes, including status epilepticus, which can be the presenting event in a lot of patients, being highly refractory. Absence, typical atypical absence, that's kind of the milder end of the epilepsy spectrum and is more commonly associated with the loss of function variants. Your focal seizures, this being the most common pediatric presentation, and then your generalized tonic-clonic seizures and tonic seizures such as Lennox-Gastaut that can present severe risk for SUDEP and the like. And so SUDEP is a very, very important discussion when it comes to CACNA1A, just like our other channelopathies such as SCN1A, Dravet syndrome. And so patients can have prolonged central apnea. So there have been recent literature that highlights that, especially in gain of function mutations. And there is this higher concentration of the voltage-gated calcium channels in the brainstem that can trigger this profound spreading depression, shutting down the breathing centers. And so this becomes important, especially in patients that have refractory epilepsies with features of generalized tonic-clonic seizures or status epilepticus, of having some kind of respiratory rescue plan or family counseling about SUDEP in high-risk mutations. All right, so the core, I guess, feature that helps us decode or get a better or closer, more optimized understanding of what the expectations of a certain variant would be is this dichotomy of gain of function versus loss of function. So the big picture is gain of function mutations produce channels that are able to open at lower thresholds, meaning they're very hyper-excitable and they activate slower, conduct excessive calcium. And so these variants typically present with more severe phenotypes, like your developmental epileptic encephalopathies, Lennox-Gastaut, prolonged status epilepticus, your hemiplegic migraines, whereas the loss of function variants, usually those are like frameshift mutations, nonsense, and they reduce calcium entry. So these present with refractory absence epilepsy. One hallmark feature that has been associated with loss of function in one cohort that was looked at is more than 90% had downbeat nystagmus. And so that would be like an easy test if you have a patient presenting with atypical absence epilepsy features or refractory absence epilepsies, assessing for that downbeat nystagmus can be a clue. And then there is the more severe phenotypes that can be associated with loss of function more commonly if it's a double negative variant. And then more than 50% have paroxysmal tonic upgaze. They can have other epilepsy phenotypes as well that I didn't go into detail with that. So just looking at the kind of the end of the two spectrum. So even though we have on this side loss of function variant and on this side gain of function variant, you can see that LGS or the severe phenotypes can be present in both of those binaries. So you have to have a better way of looking beyond those binaries. And I think that is something that is still evolving. And one recent study in 2025 tried to decode a little bit more of an understanding around those. So in this study, where they looked at several variants, missense variants, they did find about 50% of them had loss of function. And they found that there's like two functional axes or two things that we can look at. Current density and voltage activation, like how much current we have and how soon are the two dichotomies. And that gain of function variants appear to open earlier at lower potentials. Dr. Helbig has a great blog post. So Dr. Ingo Helbig is one of the experts at CACNA1A at Children's Hospital of Philadelphia. He happens to have a blog centered around neurogenetics and has a great explanation of the findings of this study called Decoding CACNA1A. All right, so beyond the epilepsy, which I think is really, really important, because when patients come to us, they come, they come as a full package, a full spectrum of different concerns. And so it is really important, even when we are super specialized, that we are able to fully understand the spectrum of what could happen within a certain genetic condition so that we can take care of the child as a whole. So there could be a lot of other neurological comorbidities that and neuropsychiatric comorbidities that are associated with this disorder. So that includes cerebellar atrophy, which is a hallmark structural feature, which can progress at times rapidly or present early in the congenital phase or later in life. There are the neuropsychiatric features, autism being one of them, speech developmental concerns being another. And so it's really important to know that the epilepsy does not exist in isolation, and it is part of a complex neurodevelopmental spectrum. And it also highlights the importance of the cerebellum in a lot of our cognitive abilities. So there are certain there have been studies that show that certain mutations in certain parts of the affecting certain parts of the protein are related to certain phenotypes. So this is what they call the S4, S6 rule. So mutations that are around the S4, which is the voltage sensing area, or the pore lining segments of S5 and S6 have a higher risk of status epilepticus and severe cognitive delay, whereas the N and C terminal variations, so those are the variants that are kind of at either end, either at the beginning of the protein or at the terminal end of the protein, have kind of the milder phenotypes, such as the classical paroxysmal episodic ataxia. And so mapping a new variant to the physical coordinates on the channel can give some immediate cues, although not absolute. Right, so pharmacotherapy. I'm not going to go into too much details of pharmacotherapy, as this is not the goal of the presentation, but just some highlights. So certain things to keep in mind is with your loss of function variants, avoiding sodium channels, because that can further reduce the synaptic transmission, and opting for the safer empiric choices like your valproic acid or Keppra or topiramate, which we know has multiple pathways as a more of a quote unquote dirty drug. And in patients where migraine may be featured, can have overlapping dual use. Some precision therapeutics that have been looked at, Lamictal being one of them, again, not for your loss of function variants, since it's a sodium channel blocker, but in your gain of function variants, because it does seem to have a specific P/Q type channel, calcium channel blocker, and was proved in some cases to be effective. Acetazolamide is something that we use more of a targeted therapy for your episodic ataxias and your paroxysmal tonic upgaze and the like. And then the newer things that are in the pipeline, which is the antisense oligonucleotides, your ASOs, to rescue specific protein mutations. So I'll go into those in a little more detail. So your antisense oligonucleotides, what are those? So essentially think of them as these sticky notes or RNA patches or fixes where you have the protein, not the protein, the gene, and you have the messenger RNA that is about to form the final channel protein. And essentially, these ASOs go and either silence a bad copy in your gain of function variants or skip a broken step in your loss of function variants. So they're able to tell the cell to shred that bad copy so it doesn't cause quote unquote a jam in the circuit, or mask the error so it can skips over and produces a more or less stable working channel. And this seems to be the closest to actual trials. I mean, it has been successful in animal models and other models. So, all right. So going back to the patient that prompted this interest, so he was actually referred to me for management of headaches by my epilepsy colleague. So I went ahead and tried to kind of fully understand the spectrum of his presentation, especially in relation to CACNA1A that was uncovered in 2024. It was clear that there was a frame shift mutation, but at that time I could not make sense of what that meant. Even the report said loss of function. It was hard to decode how that clinically was relevant to his presentation. It was clear from conversation with Dad that he was worried about three different things. Epilepsy was kind of lower on the list. The seizures were fairly more or less well controlled. He still had episodes here and there of staring episodes, and then other episodes that Dad described as mouth chewing episodes. The two primary episodic conditions he was worried about was episodes where the child was crying, saying his head hurt, and then he kind of grabs onto the person that's closest to him for support because of unsteadiness, followed by vomiting and vertical upward eye movements as well. And so I decided to have a conversation with expert in the field to try to make a little bit more sense of the specific variant, especially in the light that his seizures seem to be more or less better controlled than what I was reading about CACNA1A. And so I had a brief consultation with Dr. Ingo Helbig from CHOP to talk about the patient, and it became clear that this patient's loss of function mutation was on the milder end of the spectrum, and that gave the leverage to be able to counsel the family more effectively, to dissuade father's fears of SUDEP and the like, because of the things that he was being exposed to in terms of information around CACNA1A, and initiate the targeted therapy for the episodic ataxia. All right, so summary and clinical takeaways. I think it is important to understand that CACNA1A is no longer just a paroxysmal disorder. It's a neurodevelopmental disorder where early seizure control is imperative. It's important to understand the differences between loss of function versus gain of function dichotomies, and to also understand the limitations of those dichotomies in trying to counsel patients. And then the 50% functional baseline, the study in 2025 establishing nearly half of all the missense variants are complete loss of function, which provides a predictive benchmark. And then the ASO precision grid, which is hopefully in the works of trying to either silence gain of function variants or rescue the truncated functional proteins. And thank you for your attention. I think we have plenty of time for questions, and apologies for the delay.
Thank you, Dr. Hala,
Yes.
for this very clear topics about the CACNA1A epileptic and clinical phenotype. And I think it is very important in child neurology to have a detailed semiologic analysis of the child, but also of the parent. And particularly when we have genetic results, it is important also to give to the to the patient, but also to all the family, and multidisciplinary care. It is very important.
Totally.
So there is some question in the box. So the first one, and I think you have give them some explanation, but perhaps we can discuss more. So the question, after such diagnosis, what is the implication for treatment and management for patient?
Mhm. Let me stop sharing here. So in terms of treatment and management for this specific patient, is that what they mean, I assume?
Or perhaps for in general for the CACNA1A.
For CACNA1A in general. So it depends on the type of variant that you're confronted with, and the phenotypic presentation of the patient as well helps inform your care. At this point of time, we don't have like specific precision therapies for individual variants or individual patients with particular variants, but so your management is not going to veer far away from how you would manage epilepsy in a standard manner. So if you're confronted with a patient that is presenting as absence epilepsy, and you know that they have CACNA1A, possibly you're going to start with Depakote first and skip the ethosuximide, as Depakote has a lot more properties to help modify those calcium channels. Or a patient that presents in a Lennox-Gastaut syndrome manner, then you're probably going to use the same tools that you would typically manage Lennox-Gastaut syndrome. So I think knowing at this point in time, just because of the lack of targeted therapies, pharmacotherapy management is mostly going to be what medications to avoid.
Yeah.
For example, for loss of function variants, and not so much of what medications to try, although there are some that may be better than others, like your topiramate, your Depakote, and the like.
Yeah, but also when we can avoid like in this situation, sodium blockers that can aggravate the clinical situation is also an important decision, and it can give an improvement for patient. But because we can have um, a secondary worsening epilepsy because the use of any medication also. It is also an important decision.
Yeah.
The second question, did you use pharmacotherapy with acetazolamide in addition to anti-seizure medication? The
Yes.
acetazolamide.
For this particular patient, we did add acetazolamide to manage the episodic ataxia, which did provide significant benefit. Unfortunately, we were not able to optimize the dose further because of the metabolic acidosis. So our next step is actually to get the patient to Children's Hospital of Philadelphia for more guided treatment options.
Okay. Other question, in CACNA1A loss of function, there is any phenotypes for autistic spectrum disorders is severe or not? It's about autistic
If they are
spectrum
severe.
disorder. Yeah, there is very severe phenotype or not?
Yes, so in terms of cognitive delays, intellectual disability, autism spectrum, and the like, you can have more severe phenotypes with your double negative loss of function mutations. I'm not entirely sure if on the milder end of the spectrum, if you could possibly have more severe autism, that I'm not entirely sure of.
Yeah, but the patient have developmental encephalopathy or developmental and epileptic, and the autistic symptoms are associated to the phenotype and not a particularly an autism disorder alone. It's not an autism disorder alone. It's,
Yeah,
do you
it
mean
is
this difference? So it is not an autistic spectrum disorder alone, but a developmental
a
encephalopathy.
consequence.
Yeah,
Yes.
consequence, and they are
Yes,
associated.
definitely. I agree.
If there's this gene included in some panel for psychiatric disorder like autism spectrum disorder, I'm not sure. It's not a mean gene for autism. Perhaps not.
Is it a gene that so in autism spectrum disorder cohorts, it was found 2 to 3% to have CACNA1A. And could there be patients in I think it speaks to the variable penetrance of this condition. So there could be patients where autism is the only presenting feature. What I at least understood from the review of the literature is the 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 effect of how the channel functions it's not just about an electroclinical effect. There's actually a developmental effect, meaning because we have to remember that children in the first few years of their life, they are still there's a lot of brain wiring that's happening. There's myelination that's happening. There is connections that are being made. And so you can imagine if you have a dysfunctional gene that can impact those connections and wiring, you can develop effects that are just beyond the electroclinical picture.
Yeah, of course, yeah.
And for instance, in this particular patient, although the mom, quote unquote, is asymptomatic, I suspect she has some kind of intellectual delays because father is the one who guides the whole treatment. In most occasions, she doesn't really have much questions for me, and so I suspect she has some kind of intellectual impairment that's just undiagnosed.
Yeah, sure. So we need also to examine parent in
Yes.
neurology. Yeah. It's
Right.
important to.
That's right. Yeah, absolutely.
Thank you. Another question from Birat. I'm studying molecular biology and genetics in Turkey. Thank you for this speech. The question, your slides show that nearly half of missense mutation are actually loss of function. Since a single mutation can change both, how much current flows and when it happens? Why is a single gain versus loss?
I'm not sure I can answer that question. I think that is above
Very, yeah,
my pay grade, as they say.
very specific question.
Right.
But
Good
do you think
question.
that a single mutation can give loss of function and gain of
Yes.
function, the same variant? I'm
Yes, there has been reports that the same variant. Well, that's actually a good question. I'll have to pause and think about that.
okay.
My
So
understanding
we can send an email to.
there has been report that the same variant can cause like different spectrum of severity. Whether that different spectrum of severity is related to gain of function versus loss of function, I'm not sure about that.
Yeah.
Yeah.
Okay. Another question. In your case, what was the pharmacological treatment? So I think you respond to the question.
Yeah.
Another, is there any rule for calcium channel blockers in gain of function variants?
Yes, there has been I don't know how well it is used in terms of epilepsy, but I know that it is used in terms of like familial hemiplegic migraine and those kind of paroxysmal, episodes. But um, to my knowledge, and again, I'm not an epilepsy specialist, I haven't seen it or encountered it being used, especially for epilepsy. But yeah.
Mhm. Okay. Mm, the same question about can loss of function and gain of function any lab results helpful? Can loss of function or gain of function any lab results helpful? Perhaps they asked about if we have a result of a genetic testing. How can we say, excuse me, if there is a loss or gain of function?
I see. Would the results show that?
Yeah.
At least in the standard genetic reports, obviously they will give you just a generic gene summary, which can be confusing because it's going to list everything under the sun. And then usually under that or somewhere in that report, there should be specifics of the mutation, either saying that's a missense, nonsense, frame shift, and kind of relating it to, is it a loss of function or a gain of function, or has it been demonstrated to be a loss of function or a gain of function in certain patient populations. So yeah, it should be included in the report, but you have to kind of read the whole detailed report.
Another question, I don't know, PT can be patient or parent present without ataxia? Can
Yes.
the patient perhaps?
Can patients present without the ataxia? Is
Ataxia?
that what? Yes, there are patients that don't have the ataxia phenotype.
And you showed some patient with severe hypotonia. So
Yeah,
ataxia can be missed, and hypotonia it's a cerebral sign.
exactly. Exactly. I can imagine the congenital ataxias present with like severe hypotension. Absolutely. It's a very important point because that gets missed. Yeah.
I think it's the last question. Following your initial case, do you recommend exome or exome sequencing in any case of absence epilepsy? Yeah, I will. I will ask this
I,
question.
I mean, I was in Mauritania for 5 years, so I can tell
Yeah,
you that
there
it's
is
very
some
hard to get
specific,
exome.
yeah. If there is some particularity for absence epilepsy
Right.
related to CACNA1A gene.
Right. No, so absence epilepsy, if there are atypical features, so if it's
Mhm.
early onset absence epilepsy, or it's refractory to treatment, especially if there is some underlying developmental delays that the child has, then in that case, I would consider whole exome. I mean, I'm lucky I'm here in the US right now, so it's easy for me to be like, okay, if you fail a first line, I can go ahead and do whole exome. But I would say from clinical judgment and also just management of resources, because resources can be
Yeah.
limited, if there's underlying developmental delays and there's refractory absence, then definitely something to consider. And then in your absence epilepsy is more common in your loss of function variants. And in one cohort, they did report that downbeat nystagmus. So basically, if you have the child kind of look up, you will see like a downbeat nystagmus in over 90%. And so that could be a quick clinical clue. Especially, I mean, having practiced in Mauritania, I didn't have access to all these tools. Sometimes we had to just piece things together. You like also if you had an atypical presentation of absence and you were considering imaging and you saw cerebellar atrophy, that also may be a clue that you are dealing with CACNA1A and need to do testing.
Yeah. In our practice, when we have early absence epilepsy and refractory, we think for the first diagnosis to deficit in GLUT1.
Right, that's
We
true.
tested glycorrhea, but really
Right.
we don't think to CACNA1A. So
Right.
perhaps it's not easy, but when you have absence epilepsy, we don't think to have an MRI and to look if there is any cerebellar atrophy. But I think it is important. Now we can change our clinical evaluation of patient, and we can think to some particular gene, and we can find some mutation if we have a good clinical evaluation, and it is very important. Perhaps in source limited countries, we don't have the possibility to do a whole exome sequencing for all patients, but I think we must select the patient who are who need genetic testing to improve our treatment, and to avoid also some anti-seizure medication who can worsen the epilepsy.
Yes, absolutely.
Okay, there is no other question. So thank you, Dr. Hala,
Thank
for
you so much.
the overview of this gene, and I hope see you in other webinar. And
Yes.
for the participant, you can complete the survey to be able to have your certificate. And so thank you all. Thank you, Jessica, and see you in the next webinar. Thank you very much.
Thank you so much. Take care.